but we are just relying on the death. So all the OPD attendances by women and children went down in COVID times. Number of antenatal visits, so the routine antenatal care, the women coming to hospitals for that or the primary healthcare centers went down after being born. Number of deliveries in the healthcare facilities came down, which means a lot of these births, so the births were happening, but they were now happening at not in the healthcare facilities. So actually, we don't really know the full impact of what was going, but we knew that the healthcare facility births went down. And similarly, because these people were not coming to hospital, we saw actually paradoxically a fall into hospital. Similarly, the uptake of vaccination came down as well. So overall, we saw in all areas of MNCH, we saw a decrease in the coverage in the COVID-19 pandemic, and this is we think is an under services, antenatal delivery care, newborn, child health, nutrition. All these were significantly decreased during our time when we looked at the data. So just an overview of how the healthcare system works. It's the level 1 and 2 that was broken down, that and further levels, and all the referral system was broken down as well, having an indirect effect on these outcomes. So we've talked a lot about UHC, universal healthcare, and its essential health package covers, for RMNSH point of view, these 12 major comps are very, very important, and this as well. So what are the key challenges? Obviously, we know that our healthcare system is poorly funded and sadly poorly governed. There is inadequate and inequitable access to universal health coverage, and the quality of care is not consistent. There are this number going down further in COVID times because of the hospitals shutting down, lack of supplies, doctors or healthcare professionals not being able to work because of lack of PPEs. Then there are frequent health emergencies. Our healthcare system recovers from one thing.
Dr. Sali, if I may request you, please.
Yeah, we just finished it. And discuss these key priority areas for MNCH. We need leadership and coordination mechanisms, and then to be able to implement that at a grassroots level, working along with our partners, particularly private sector, which is a particularly strong healthcare sector in Pakistan, and also to target where it's needed most, i.e. poor and rural communities and uneducated masses. And again, tackling the health workforce crisis, improving the doctors, and then developing the system for timely referral of these cases from doorstep to the facilities where they can be looked after better. And most importantly, to be able to collect the data and to be investing in information systems so that we can actually capture the full extent and direct our resources for for future. Thank you.
Thank you so much, Dr. Sadia, for sharing your research and talking about the mother and child and the challenges. So, ladies and gentlemen, now let's move to the next Dr. Muhtaz Ali Khan, Scientific Officer at National Institute of Health. National Institute of Health is very actively playing and performing its role in the context of vaccination and the COVID-19 scenario. So I personally has the honor to visit him and to show some of his work, vaccination, the challenges in Pakistan, and how it is what actually NIH is doing. So, Dr. Mumtaz, over to you. Please share your thoughts and your work regarding this vaccination and COVID-19.
Thank you so much, sir. I will go briefly step to step because this is really a huge topic, but I will try to cover within stipulated time. So I will be talking about these three topics briefly: operational challenges in the early days, response at point of entries, because these were very important in the early days and even still, and COVID vaccination. So, Pakistan could be a high population in its struggling healthcare system challenges with relatively mild repercussions. The world health system was another challenge, resulting in poor coordination across the sectors. COVID-19 pandemic started in Pakistan, and we had first case on February 26. We reported from Karachi. The cases were reported from Karachi and Islamabad, and then it created a great panic because we were sandwiched in two epicenters, Iran and China. Early operational challenges were many, and a few are listed here for such novel virus outbreak. Epidemic of Pakistan was proved to be the backbone of these operations because many of our fellows trained workforce were present in provinces and also in the point of entries. Quarantine centers and isolation rooms were a new concept for administration and general public. We had few isolation rooms in the diagnostic capabilities were nearly limited. Like NIH was the only center who was capable to diagnose novel viruses. So what the government started trainings, and during these trainings, NIH, Health Service Academy, Central Health Establishment, and provincial health departments conducted extensive trainings and simulation exercises throughout the country. HSA supported in development of training modules, manuals, SOPs, and guidelines initially, and partners like WHO, CDC, Public Health England, and JSI supported these training activities across the country. Keeping the limited trained manpower at point of entries, the government deployed extra manpower from other institutions and trained all the staff across the country. The 15 point of entries were operational nowadays and even that time. And also we trained the staff on sample collection, transportation, and conducted initially during this pandemic. Fortunately, at NIH, the public health EUC was already established in 2018 and was used for dengue outbreak in 2019. And this was great experience, and we activated this EUC for COVID response as well. So the public health UC at NIH was the center of operations, and accordingly, when COVID cases detected at China, public health UC was activated on 21st January 2020 and deployed coordination mechanism, and also we deployed extra staff from the other departments of the institute. This was the structure of public health UC we established during January and February, and with the role and responsibilities and also the functions of UC. FLTP workforce, as I mentioned already, we have completed 12th cohort, and now we have 13th cohort of this course, and as a Ronald Devolved FLTP program. And thanks to FLTP, shall contact tracing epidemiological services and response at local level and engage in rapid response activities throughout the country. NIH and FLTP developed these guidelines and SOPs. These were available and are available as well on the website of NIH for general public, for doctors, and for media. Then, keeping in view the burden of disease, the poor coordination because of this 18th Amendment, the National Security Council established the National Coordination Committee, which was chaired by the Prime Minister with all provincial chief ministers, to establish an operational arm, the National Command and Operational Center, to ensure effective coordination between the federal and provincial levels. And this civil military constitutes response to COVID-19, and indeed it is a success story in Pakistan to cater and respond to COVID-19 like structure of NCUC, and it is really a lesson for us for the future outbreaks. These are the NCUC every time with update of vaccination and COVID patients. No doubt, polio UC played an important role during this outbreak. COVID testing facilities were only limited to NIH initially, and then was extended to the whole country. And nowadays, we are able to perform more than 60,000 tests per day at district level and also at private level, and also deployed mobile lab at Sudan border. It is an important part of this outbreak because many travel-associated cases are coming to spread virus in Pakistan and other countries. NIH, along with the Central Health Establishment and HSA and other health department, started this work initially and still working to train persons at point of entries. We established point of entry operationalized at Taptan, and also the Minister for Health of that time, Zafar Mirza, visited the operational situation, and this was another success story, and also deployed mobile lab at Taptan border. This was the Pakistan House as quarantine for pilgrims coming from Iran. So these are some pictures from the training and simulation exercise of point of entries. I'm skipping a few slides because of shortage of time. These are the screening data shows these are the isolation areas and provision of basic facilities. Some quarantine centers were established in hotels, and where their hotel were not available, these were established in tents and the ground crossing like Taptan border. Countrywide lockdown, smart lockdown policies, waiting hall, education institutions closure. These were the strategies performed during this outbreak, and also the risk communication. It was an important area, and Pakistan used an innovative method with Pakistan messages on mobile phone with every ringtone. This was another innovative area which helped us a lot. So tech retail code weeks, 7% or 24% are fully vaccinated. This is last week figure. 23 partially vaccinated. We have good progress, no doubt. Almost 51 or 52 million people are vaccinated till date. You can see these doses. Pakistan is report. If we compare Pakistan with other countries around, Pakistan is really lagging behind, and we have to improve the vaccination status, because vaccine can help you from even from severe disease and deaths. If you see these two slides, which I have included from England and also from Chile, the fully vaccinated and partially vaccinated with booster dose and fully vaccinated with booster are protective, showing protective effect from severe disease and deaths. So we have to educate for vaccination. And I also started mobile vaccinations in Islamabad, and then urged the other provinces and other departments to start this. And also elderly and disabled people vaccinated at home. We also started production. This was really a good news for Pakistan and embassy staff, and also we are providing stops and also booster dose. These are some pictures from diplomatic vaccination process in IH Islamabad. And these are some major countries staff we have vaccinated. So thank you so much.
Thank you, Dr. Mumtaz, for sharing very informative picture of the vaccination in Pakistan and the global perspective. So, ladies and gentlemen, as we started a little bit late, and we'll try to finish this after listening all these Mr. Michael, after Dr. Shizad Ali Khan. Dr. Shizad, over to you. Dr. Shizad, are you there? I think only. Okay, ladies and gentlemen, let's have a message from WHO and your views on this.
This is the keynote address that Dr. Palita gave it to read to the panel on, I'll exactly do that. We should know that Pakistan is the 5th most populous country in the world, with a population of over 2, is administratively managed at district level. That's the higher healthcare health interventions, that the country also has a relatively large primary healthcare infrastructure, which includes over 5,000 basic health units, 10,500 other first-level healthcare facilities, and over 100,000 lady health. And then this is supported by a network of about 1,000 secondary care hospitals at tertiary and district level, and tertiary care for teaching hospitals for referral. He alluded that despite all these structures, there is high population growth, there is an uneven distribution of health professionals, there is gap in healthcare infrastructure, there is insufficient or inadequate funding. Noted that conflict, disasters, and other crises in the country have had a profound effect on the healthcare systems and result in extremely grim situation. The impact of weak governance may result in generations without adequate access to social for health and welfare. Risk in health facility is key to adherence to public health measures. That despite all shortfalls, the overall response remains satisfactory. The government will support crisis communication and community engagement. To a certain extent, and has appreciated the knowledge globally. However, Dr. Paletta also noted that there is some areas for improvement, especially in establishing a robust governance mechanism through a well-designated mitigation and preparedness of bodies like the NCOs do equitable deployment of health workforce with discussions. There's also need to rethink of the various tiers of the health service provision levels. There's need to strengthen the information management systems. There's need to think about the supply chain management before and during emergency. There's need to think about also community awareness and resource mobilization. Right now, a lot of money has been used to support the COVID-19? What next in future?
Thank you so much, Honorable Chair. Dr. Palita. Side. Although there are a few questions, but I Honorable Chair, Dr. Michael, Professor challenges which are associated with for your time, for your